The most important thing is to turn off the exposure. I like to give the analogy of a tub that's overflowing. And so while we can treat them, which is opening up the drain to the tub, the most important thing is that you're turning off the faucet.
This is Good Outcomes with Dr. Dave. Welcome to our Clinician's Corner segment where I reveal how we get good outcomes in our successful PT practice. And I'm your host, Dr. Dave. Let's get started. Hello, everybody. And today I want you to imagine having all kinds of gut problems, feeling exhausted all the time, not able to think clearly with brain fog and lots of things that you know are wrong. You've been to multiple physicians, multiple practices, and for the most part, everyone's telling you that everything looks fine, but you know it's not. And so today we're actually going to be talking about two conditions that leave people feeling trapped in this cycle. First is mold toxicity, and then the second is Lyme's disease. And so they share many symptoms. And so what we'll be doing is we'll be discussing the similarities and differences between their presentations and their treatment models. And to do that, today I have Jessica Ham, who is from Regenesis Performance, which is an integrative practice here in Pensacola. She treats patients and helps them uncover potential root causes when traditional approaches haven't really produced many results. She entered the space when a close family member suffered from disabling symptoms that traditional medicine couldn't find. In 2006, she graduated from Southern Illinois University with her master's degree as a family nurse practitioner. In 2017, she completed a fellowship in anti-aging and regenerative medicine. And so, Jessica, thank you so much for joining us here today. Can you first tell me why you choose to go through that fellowship after being a nurse practitioner for so long?
I think it was just born out of necessity and desperation. As you said, I had a family member that was suffering from disabling symptoms and that we could not find answers to despite, going to numerous different doctors. So we were introduced to actually Dr. LeMay, which is the owner of Regenesis Performance. He had a knowledge base that was just way outside of what we were accustomed to. And so the curiosity led to us taking my husband, when I say us, my husband and I, who decided to take a course in anti-aging and regenerative medicine, and then quickly just dove into the full fellowship. During the course of this, we were able to figure out that at the root of the issues was both mold and Lyme. And so it just became a pain to purpose, type switch and focus of my career from kind of traditional family medicine to integrative medicine.
I feel like a lot of people have this story where they are medical providers, run into problems they can't solve with the traditional model, and then start looking elsewhere and investigating. And what do you know? It actually turns out to have some results for them.
Correct.
And that's what you had. I know for me, my wife and I, we went through some health issues a number of years ago, and it's the same thing. It's those experiences that I don't know if I would have been as open if it wasn't for those symptoms and troubles that we had. And so one of the things that we need to make clear is what is the difference between a traditional allopathic model and your more integrative approach in its simplest form?
I think the difference is what versus why. So in the traditional sense, the focus is heavily on what is the disease and what is the medication or the intervention to treat it. And the question in the integrative model becomes more so, why is the disease? What was the trigger? And how can we reverse it? So one of the biggest questions that we ask in integrative medicine is, when do you remember last feeling well? And creating a timeline of events of, what was going on in your life at the time, what may have been the epigenetic trigger that turned on the current condition that they're suffering from.
Once you establish a timeline, what's your next step in your evaluation?
Probably testing
Okay.
and kind of narrowing down, where do I think, the problem lies. And when you have a patient with a multi-system, multi-symptom type of condition where they might have 20 plus symptoms, recognizing that there is one common driver to that is the important piece. And I think that's where a lot of times this gets unrecognized because you're looking through a very narrow lens. Maybe a neurologist
Mhm.
um, is looking through their lens of why is there a headache, and not connecting the dots that the neuro condition is connected to the gastro condition, which is connected to the cardiac condition.
It sounds like one of the biggest differences between an integrative practice like yourself versus a traditional model is that we are segregated in our professions. The neurologist is looking at the brain and the nervous system, the nephrologist is looking at the kidneys,
Yeah.
and what you're trying to do is integrate and look at it all as one big happy system that's supposed to be talking with one another. And so would you find that difference is kind of where some things are missed?
Yes, because I think it works in the majority of cases, this kind of algorithm-based medicine, because you're usually dealing with an isolated set of symptoms,
Mhm.
where you might just be coming in because I have one or two symptoms. But in these patients that can have numerous symptoms, the water is very muddied. And so, you kind of go to all of these unique specialists who
Mhm.
are not connecting the dots that it's all part of one syndrome.
So let's say someone comes in and they have a plethora of symptoms. What would be the cluster of symptoms or history that would lead you to think, okay, this might be mold?
Okay. Mold can present in, like I said, can cross all different systems. So one patient can look very different from another. And some patients may be heavily symptomatic in the nervous system, where they might have dizziness and headaches and brain fog and lack of concentration. They can also have palpitations and tachycardia. They may have a lot of gut symptoms. Bloating, abdominal pain, alternating constipation, and diarrhea. They can have blurry vision, red, teary eyes, sinus congestion, pain syndromes. They can have sharp shooting pains, muscle pain, um, skin rashes can occur, hives can occur. So it can be a big bag of symptoms.
I'm assuming not every patient comes in with the same symptoms.
Correct.
And it sounds like some people have this or that, or some of these. Why does mold present in so many different ways?
I think patients' genetics can have a role, and what other burdens they're carrying within their body and what systems may already have been weakened because of other existing pathogens that might have already been present. Usually, mold is a condition of it's a perfect storm. A lot of people can be living or working in a moldy environment and be okay. Maybe they have some respiratory symptoms. They have more allergies, more upper respiratory infections, asthma exacerbations. But usually there's some type of event. Maybe it's an exposure to a virus or a major life stressor that pushes their immune system over the edge to where suddenly now they become symptomatic in all of these other areas.
So then what exactly is mold? Because I think most people know mold bad, but I feel as though everyone's exposed to mold all the time, especially here in Florida. So like what kind of creates the symptoms if everyone's always exposed to it?
Well, there's a genetic susceptibility.
Okay.
So there is an HLA defect that about 24% of the population carries. And the HLA defect affects the communication between the innate immune system and the adaptive immune system. So the innate immune system is the part of the immune system that responds immediately upon a threat. It's kind of like the security alarm.
Mhm.
Whereas the adaptive immune system is the smarter side. It's like the facial recognition system. So it has memory cells. And in a genetically susceptible individual, they lack a communicating cell. It's an antigen presenting cell that can communicate from the immune system to the adaptive immune system that, hey, I need help. And so the innate immune system, because that lack of communication, can remain chronically inflamed.
So we have two sides of our immune system. One is the emergency response first order, and then there's the kind of the long acting immune, and there's a miscommunication there. And that's the HLA defect.
Yeah.
I understand. And so when there is a miscommunication, is the main problem that the second order doesn't get activated, or it's activated all the time?
No, it's that it doesn't get activated appropriately to clear the pathogen.
I understand. Okay, so then you're just in this initial state all the time?
Correct.
And what's bad about the initial state all the time?
It's just chronic inflammation,
Mhm.
inflammation, interleukins, cytokines, TNF alpha. We can look at a lot of these innate immune system markers, and this side of the immune system hasn't been as well understood
Mhm.
until the last 20 years. I think the Nobel Peace Prize was won in 2011 for studies on the innate immune system. We're most familiar with memory cells and antibodies, B cells, T cells. So it's kind of a new emerging area of looking at the innate immune system.
That's really interesting because in our practice, we are the science suggests what we're doing is we are finding interleukins and TNF alpha trapped in the tissues and then opening up the pathway to get them out.
Mhm.
And that is the innate immune system uh, starting things and then never stopping. So let's say you identify a patient that's definitely has mold. What are the testing that you're doing aside from maybe some genetic testing? What are the other things that you're doing to confirm or understand the illness further?
There's several things. A VCS test, a visual contrast study, is a vision test that you can perform online. You can go to a website called vcstest.com, and it will assess your ability to detect contrast. And there's also a symptom questionnaire that's included in that. And it was a test developed by the military to screen pilots for biotoxin exposures. So, about 90% of people that have mycotoxin burden will fail the test. So we look at the test itself, and it's an accumulation of mycotoxins that accumulate in the retinal artery, making it difficult to detect contrast, contrast of gray. And so they typically will fail on a few different lines. And then we'll also look at the symptom questionnaire of how many symptoms, do they have alongside. So it's not 100% that it can be other toxins that the patient is exposed to, but it's a very cheap way to it's only $15 to do the test online. So that's one screening test that we will use. And then we can look at some innate immune system markers, um, vascular endothelial growth factor, um, TGF beta, MSH. These are all tests that were discovered by Richie Shoemaker. And so I've kind of adopted this kind of hybrid model between, all the leaders in the field of looking at some of the innate immune system markers, the genetics, the VCS test, and then the most recent development has been looking at urine mycotoxin screening, where you're looking at urine metabolites of different molds that you might be exposed to through inhalation or through food.
So are these just standard blood tests and urine analysis?
So the standard blood tests that you can get through LabCorp and Quest are the HLA and the innate immune system markers. The VCS test you do online,
Mhm.
and then the urine mycotoxin test is probably not considered standard. It's more of a new science that's been developed. So it's typically not covered by insurance, that particular test.
Okay.
It is a first morning urine specimen. So you're allowing urine to collect overnight, and then sending it in, and they can give you a threshold of what is considered normal, and what is considered not normal, because certainly everyone is exposed to mold.
Other than the genetic factors, what are some other reasons why people will build up? Because it sounds like the body is supposed to be doing its thing. We're going to be exposed, and then the body's supposed to clear out these toxins.
Mhm.
Are there certain lifestyle factors or things or food or diet that actually hinder a person's ability to clear out these toxins?
There's some knowledge that patients that don't have as high of an omega-3 content in their blood, so DHA specifically is very protective to glial cells in the brain, that allows them to be more resilient to mycotoxins. People who have a diet that might have increased exposure to different herbs that are naturally antifungal, may be more resilient. And then I think it's a dose dependent type of exposure. Some people might just intermittently be exposed, and at church or in places that they're not spending hours upon hours every day. So I think the most significant impact is when the exposure happens at home or at
Mm,
work or at school, somewhere where someone spends a considerable amount of time.
I understand. So it's actually a big factor of this is really where are they being exposed? Because if they're being exposed intermittently, the body has enough time to flush stuff out most of the time. It's when you're being exposed exclusively in a place where you're there all the time.
Correct.
And so it sounds like that's a big part of your analysis too is where's the exposure, which is why you spent so much time in your history. Okay. So when someone's exposed, their body's having a hard time. Does it matter what kind of mold it is? And does that change your treatment?
Well, there's 5 types of molds that are most concerning: Aspergillus, Penicillium, Wallemia cebi, Chaetomium, and Stachybotrys are the 5 that are, most detrimental to human health. There's dozens of other molds.
Mhm.
So when we're working outside in the garden and you're seeing mold, that's not something that, oh my gosh, I can't be exposed
Right
to this.
away.
Yeah. So it's combined with building materials and the volatile organic compounds that are released from all of the other building materials that off gases in combination with the mold that has accumulated on drywall or in on different materials in the home.
Let's say you've identified someone who has mold exposure. What's your first thing that you're doing for treatment?
The most important thing is to turn off the exposure.
Okay.
So I like to give the analogy of a tub that's overflowing. And so while we can treat them, which is opening up the drain to the tub, the most important thing is that you're turning off the faucet.
Okay.
Having them inspect their home is the first place to start. So I typically will recommend they do a dust analysis.
Mhm.
It's called a Hertz test, and they can order that online, and they will do a collection around their house of dust, and the DNA settles of from mycotoxin settles in the dust.
Okay.
And so they can get an overall burden of, these 5 types of mold with the Hertz test. And there's a threshold again, everyone's going to have some mold, but there's a
Mhm.
threshold that if someone is symptomatic and their count, is over this, then that warrants further inspection.
When someone's other than the testing, what are they looking for in like their house? Are they looking for like I'm just picturing like a wall behind like a desk or something that's black. Like is that what they're really looking
No,
for?
it's not always obvious. Not all molds have scents. I think we all know that we've walked into buildings and you can smell some molds and mildews, but not
Mhm.
all of them have a scent. To go on the hunt, you might just look for, are there any water stains in the ceilings? Do you have a shower that you just cannot keep up with the mold and the grout? That
Mhm.
might be that there's some plumbing leaks behind the tile and the grout. You can go look underneath all your cabinets at the plumbing. Do you see any bubbling of the material underneath, indicating that there's a slow leak? It's important for people to look at outside of their house. Is there areas where there's constantly mold and mildew growing on the side of the house or on the ground? Look at the way that water, when it rains outside, the patterns that water flows, is it towards the house or away from the house? So there's a lot to be hyper vigilant about in maintaining your home. And then the AC is probably one of the most important places. So regular inspections and maintenance of your AC is important to
Mhm.
make sure we're not missing an area. And that's probably the first source that I tell people to go and do is go home and open up their internal AC unit and look at
Mhm.
the coils in the blower and see, do they see any type of fuzz, growing, whether it's white or gray, green, black, any type of fuzz in there is going to be some type of mold or mildew.
A number of years ago, we were exposed to mold, and my wife had to go through treatment for that. And one of the things we did is we cleaned our AC units and then installed a infrared light. Is that something that actually works?
I mean, it's used in hospitals a lot
Okay.
for that purpose. It also helps to kill other pathogens, but the analogy I like to give is that that side of your house that receives the most sunlight doesn't typically grow mold or mildew, right?
Mm-hmm.
So a UV light can function in that way, and then a whole house dehumidifier can be really helpful. Keeping humidity levels in the home below 60% is important for preventing any mold buildup.
Yeah, we got one of those too. And it's funny how you go into the deep dive of, okay, how do we prevent this from happening again? Because there's almost like this PTSD about it. Like you see mold, and like the literally this past weekend, I noticed there was mold on our sliding doors out back of our house, and I like freaked out. I'm like, I need to clean this immediately,
Yeah,
and because I'm just afraid of my wife getting sick again.
yeah,
I probably don't have the genetic markers. My wife obviously does,
yeah,
and because we both were exposed, or our whole family was, but she was affected, and it barely touched me. At least I didn't seem like it felt like it got me. And it was this whole crusade against mold in every way. We had to research. We bought these candles and the cleaners that are good anti mold, and um, it's amazing how much that experience like reshapes the way you see things.
mhm.
After you deal with the exposures, what are you doing in someone's life in terms of treatment that helps get the stuff out? How do we open the drain more?
Through binders. So mycotoxins circulate and exit through enterohepatic circulation into bile. So we want to use binders to capture those mycotoxins as they're exiting through bile into the small intestine.
So just to clarify, they are circulating through essentially the liver and its production of bile.
They're transported through bile into the small intestine. And
Oh
that is
wow!
the opportunity in which we can capture and exit through bowel movements,
So then, if you're not binding it, it's
reabsorb.
reabsorbed. Oh, okay, and it's reabsorbed, and then is it mostly in the liver? That's because the liver creates bile
Mhm.
and then disperses it through the gallbladder into the small intestine. Is the liver the main place where the mold lives, or how does that work?
No, it can circulate it, throughout the entire body.
Okay.
So that's why it can wreak havoc in different systems.
Okay. Oh, what you're saying is that the opportunity to get rid of it from the body is when it's in the bile in the small intestine.
Correct.
It's already the exit.
Yes.
So you bind it there and then it just keeps going instead of being reabsorbed.
Yes.
I understand. And so what do these binders look like? Like what are they?
Yeah, there's lots of binders. Fiber is a binder. Something like psyllium husk is a binder. Nuts and seeds are binders. So I usually use a combination of agents to be able to achieve that. Because the nice thing about using food as binders is there's no concern that we're blocking the absorption of other micronutrients or other agents. So, and then in the traditional sense, we think of things like activated charcoal, bentonite clay, allopectin. These are all binders. There's some prescription binders that are used in the space, such as cholestyramine and Welchol. And so usually I'm using a combination of different binders. The downside of things like activated charcoal, bentonite clay, cholestyramine is they have to be taken on an empty stomach because
Mhm.
they don't have an affinity for what they bind to. They can bind to medications, other supplements, micronutrients. And so they often have to be taken about 2 hours away from any other medications or supplements that they don't bind with them.
Mhm.
And typically you can have a snack. I usually will have people eat something that's a little bit fatty to help stimulate the production of bile.
Mhm.
Maybe some nut seeds, a scoop of nut butter, a stick of cheese, or something like that can help mobilize bile and help them to capture the mycotoxins and bind them out.
So even just timing of when you're eating is really important. As a new grad PT or a young clinician, there are two things you need: mentorship and money. We will pay you a full salary to be mentored in our customized residency program right here, and it will actually help you fix those patients you know you could have helped more and prepare you to launch your own business one day if that's something you want. Apply at our website and click join our team at www.renewintegrativept.com, and we look forward to hearing from you then. Now that you've started those things, how long does it take for someone to start feeling better once you've started? Let's say you've turned off the spigot and now you've started opening the drain a little bit. How long can it take for someone to start feeling better?
I mean, it can take from as little as days to weeks. I think it depends on the constellation of the patient, how long they've been sick, what other comorbid conditions we're dealing with really tells me how long they're going to require treatment. And I would say about 50% of people will feel dramatically improved with just binders alone. And other patients might need, more layers, more steps involved in the process of getting them better.
Can you tell me maybe a case study of someone that you've worked with? I think earlier you mentioned one that was really significant for you. Can you
Yeah.
share, kind of summarize all of this in their story?
When I was going through my training, I had kind of an acquaintance that I was close to, and she was presenting with all of the symptoms that I was learning about. And so I started asking her questions about her environment. I mean, she had fibromyalgia, chronic fatigue syndrome. She had been disabled for 10 years, unable to work, on benzos, on opioids for her chronic pain. And so I started asking questions, and lo and behold, she started investigating her home. She had an air sampling test, believe it or not, and it ended up being negative. But I just had this impression that we needed to investigate further. And when they started to pull furniture away from the walls, there was actually mold growing on the back of the walls. And
Oh my God.
so this is one of those cases, my first case that I ever treated, and it was a big ask. I mean, she had to walk away from this situation and leave a lot of things behind. And this is not to say this is a very unique case. I don't know that I've had any other patient have to walk away, but I felt like it was it was God affirming that I was where I needed to be. And it was like, I'm going to give you a really strong slam dunk case so that you know you're where you need to be. And to take on this population. So anyhow, once we got her out of the home and we did the binders alone, within 6 months, she was off of opioids, off of benzos. She started a business and she lost 50 pounds. So that was quite a dramatic case.
Yeah, that's amazing. And so we can see those early gains a lot sooner than the 6 months, though. Wow. When you are like, this is mold and this is what we're going to do, and you stop exposure and you open the drain a bit with some of your, whether it's food or binders, is it like a 2 weeks? Is it 5 weeks? Like, when do we at least start to see the early signs of, okay, we're on the right track?
I usually use the VCS test as a way to monitor progression. So if the VCS test helped me to diagnose,
Mm,
then improvements on the scores of the VCS test will tell me if we're essentially draining the tub appropriately.
wonderful. And so you're kind of monitoring these things.
Correct.
Are there times where you have to pivot?
Yeah.
What does that look like?
Some patients may not respond to binders well because we're not adequately producing bile through the gallbladder.
Mm,
So some patients might need a little bit of nutritional support before I ever start binding. They
mhm.
might need some cell membrane support, with the omegas, as we talked about. So that can look like, different things that help the gallbladder open up is TUDCA, ox bile, taurine, milk thistle. So I might have them start on something like that first if I think that there's some congestion there, liver
Mhm.
congestion, gallbladder, to help them be able to facilitate the removal. So yeah, every patient looks different, and some of them might need a little bit of work ahead of time.
So you mentioned liver congestion, and I would imagine as you are getting things out of the body, is there any kind of detox or any symptoms that are going along with getting it out of your body, or is it a relatively easy process for that?
Times I think genetics play a role in that and how we can metabolize things out of the body. And some people can be slow metabolizers, and so they're more likely to experience more side effects. So sometimes there can be a temporary worsening before they feel better. It's a phenomenon known as a Herxheimer reaction, where we can just have a flux of cytokines, built up that can make you feel a little bit more fatigued, more headachy, more achy, before you get better. So I usually guide people on that. Having an alkaline diet can help with that. Increasing binders, mineralization can help with that. Epsom salt baths, taking magnesium are some ways we do that with the alkaline diet. Lemon juice, eating more greens in your diet can raise pH, which allows people to be able to filter out toxins and clear them better.
It's funny how you're listing all these things. I'm like, I remember that. I remember that. I remember
Mhm.
that. Just even the lemon juice. I remember my wife drinking lemon juice often because she was having a lot of Herx reactions that were really. Her system was obviously the perfect storm where it was like, oh my goodness, this is everything. So let's move on to Lyme. I think this is a very misunderstood disease or infection, we can call it.
Mhm.
Can you describe at its most basic level, what is Lyme disease?
It's a spirochetal pathogen in its traditional sense, and it is a stealth organism, very unique in that it has the ability to evade the immune system and evade attack by antibiotics through morphing into a cell body or a round form, which is an entirely different type of bacteria to have to attack. So, and it also has the ability to form biofilms, which is another protective way that it is difficult to treat and can create resistance to treatment.
So it is a bacteria,
Mhm.
but this bacteria seems to have its own natural defense mechanisms to evade detection
Correct?
and avoid or at least fight back against its attack on
Correct.
itself. Are there any other bacteria that are similar to it in its ability to protect itself or fight back? So what is the most common way someone gets Lyme disease?
Through a tick bite from a deer tick. The idea is that the tick must be engorged and attached for 24 hours, but we're finding that is not the case.
Mhm.
So the tick is the infection lies in the saliva.
Okay.
And so it regurgitates into the individual, and that's how they acquire the infection. And the other piece that makes it difficult is that they often transmit more than one infection.
Mm.
They can transmit other viruses and parasites. And so most people who end up being chronically ill have multiple co-infections involved. It's not just the Borrelia spirochete.
So is there more than one kind of Lyme?
There are many strains of Lyme, and that is part of why it's so difficult to detect. When they originally developed the testing for it, the ELISA and Western blot, that screens for one strain of Lyme disease, which is Borrelia burgdorferi. So we have not evolved to offering testing for the other strains through standard tests like LabCorp and Quest.
Okay. So then let's say you suspect Lyme.
Mhm.
Does it matter which strain it is? And if it does, why is that? What's the difference?
Well, the difference is in being able to test and find a positive result. So typically with Lyme testing, if we think that this is a chronic case, we cast a wide net, is what we say in terms of testing. So we will look at multiple modalities: PCR testing, ELISA, Western blot, immunoblot, fish testing, and that's because the infection evades detection. It does not like to hang out in red blood cells. It likes to hang out in connective tissue. So it can evade detection through standard blood test. And so casting a wide net allows us a better chance that we might find it.
Mhm.
But even if we don't, that doesn't necessarily exclude the diagnosis. It is a clinical diagnosis, meaning that it's a combination of patient symptoms as well as laboratory findings.
It's interesting that you mentioned that it likes to hide out in your connective tissue. Can you elaborate on maybe the implications of what that means?
Sure. So I think one of the hallmark symptoms that we can differentiate Lyme from other chronic processes, autoimmune conditions, is that it is often migratory in nature. So we think of traditionally joint pain, and it likes to move around. So once it is being attacked by the immune system or an antimicrobial and it's been hanging out in the left knee, it might jump ship and travel to a different area of the body so that it can take cover. And so, hallmark symptoms is migratory pain. It can also travel through muscle tissue, nerve tissue. So, migratory joint, muscle, nerve pain is definitely one hallmark symptom that is unique to Lyme.
What are some of the other symptoms that you're looking for to make this clinical diagnosis?
Other common symptoms are fatigue, brain fog, concentration issues. There could be some heart manifestations. I think we've all heard of Lyme carditis, which can create an inflammation around the heart. People can have gastrointestinal symptoms. They can have hot flashes, night sweats, low grade fevers, sleep difficulties, nerve pains. It can be quite confusing because it can create a lot of overlap with other symptoms like the mold. And
Mhm.
so that's why it also can make it difficult in isolating, which one of these do I need to go on the hunt for?
Yeah, because you can't test for it, and all the symptoms are very similar to a lot of other things, especially
Mhm.
mold,
Yeah.
and so it makes it very hard to diagnose. But you deal with this all the time, so you probably see the patterns. You're like, I know what I'm doing
Yeah.
here. So once you identify that someone does most likely have Lyme,
Mhm.
what's your first step?
Well, it's isolating which infections,
Okay.
and then typically it's antimicrobials. So I think we talked about the fact that there's the spirochete form, there's the cyst form, and there's biofilms, and that is where a lot of the challenge comes in because we don't have an antibiotic that treats all three of those forms,
Mhm.
right? So oftentimes it takes a combination of different antimicrobials.
Mhm.
And so I've kind of adopted a hybrid model, from all of the gurus out there of oftentimes we'll start with prescription antimicrobials and try to shift and move into herbal antimicrobials. They both have their advantages. They have both been widely studied. Unfortunately, most of the studies are in vitro in a test tube. So, patients don't present, without other variables in the picture. So it's antimicrobials. I'm usually reevaluating them every 4 to 6 weeks, and similar to the VCS test, which I would reevaluate through testing like that. I use a validated tool. It's called the Horowitz MSIDS questionnaire. Richard Horowitz is a leader in the field who has studied this for years, and he's created a tool, a questionnaire of symptoms to look at all the symptoms of Lyme. Are they improving? It's just an objective tool that I will use each time they come back to see, are we seeing any improvements in any area? And if not, then we kind of pivot, and make a change. Sometimes they'll respond to one antimicrobial better than another. I don't know if we're primarily treating the spirochetal form or the cyst form at any given moment. So that can be a challenge.
So is it the fact that there's multiple forms, or the fact that each of these forms has its own separate defense mechanism that makes Lyme difficult to treat?
I think it's knowing which form we're treating at what time,
Mhm.
as well as the defense mechanisms, as well as the co-infections that might, have an interplay. So when I say co-infections, Bartonella, Babesia, Ehrlichiosis, Anaplasmosis, Mycoplasma, these are all different co-infections that we can be simultaneously having to treat.
And are those things that can be transmitted with the saliva of the tick? Or is there other ways that they can just already have that in their system as well? Or is it usually like that's the point of entry for all of these things?
It's usually the point of entry. I mean, there's other burdens of the immune system that, may come out of dormancy, like Epstein-Barr, other viruses that they were previously exposed to that can reactivate when there's a perfect storm that hits the immune system.
So it sounds like it's just all of the above that kind of makes it really confusing. There's so many factors that you have to
Mhm.
consider while treating it that makes it difficult.
Yes.
So it's been my experience that not everyone gets 100% better with Lyme. Can you explain to me why there are some limitations to your treatments and what the reasoning is for that?
Yes. So it is thought that the cell danger response is probably a big key in that. And the idea is that the threat may have, been there. It has since resolved, but the nervous system doesn't recognize that the smoke alarm can turn off, right? That the fire is no longer there. And so when there's a threat that invades a pathogen or a traumatic event, we shift away from normal cell functioning, growth and repair, normal hormone signaling, normal energy production to focus on the threat.
Hmm.
Like I said, when the threat is removed, a lot of times we are still the nervous system is hypervigilant.
Mm.
It doesn't know that the threat is resolved and then it can go back to normal cell function. And that's why some patients may remain fatigued and have brain fog because their cells are not performing optimally.
So when the nervous system is not getting the signal that the threat is gone, what are some of the things that you can do to tell the nervous system, hey, you need to chill out a little bit
Yeah,
and recalibrate?
there's lots of different limbic system retraining programs out there that can, through regular practice, we can kind of turn off that hypervigilant cell signaling. So, EMDR is a common practice that is initiated by different therapists.
What is EMDR?
EMDR is eye movement desensitization response.
Okay.
So, it is used a lot in and military personnel who have experienced traumatic brain injuries and people that have experienced PTSD. What I usually will recommend to my patients are more self-guided
Mhm.
limbic system training programs, the Gupta program. There's DNRS, which stands for Dynamic Neural Retraining System. There's a Primal Trust program. These are just self guided
Mhm.
and they require daily practice.
Mhm.
Prayer is a way that some people achieve that. I love the fact that before it was science, it was biblical based, be transformed by the renewing of your mind. By intentional practices, we can convince our nervous system that the threat is resolved and that we are safe and secure.
That's awesome. How often do you bring your faith into your practice?
I'm probably more of an Esther. I usually gain trust, in patients before I open the door to that conversation. You just kind of feel out people and see where they're at. And I'll oftentimes just in my history ask if they're spiritual at all, to see if that plays a role, in their healing process, then I'll kind of, dive a little bit more into it.
As you go through the process of treating someone with Lyme, when should they start to feel some improvements, and does it matter? And then we'll get to the outcomes later.
I typically will see my Lyme patients approximately every 6 weeks because I don't want them to go too long without having any symptom improvement before pivoting my approach. So typically in the early stages, I will see them every 6 weeks with the goal in mind that we're seeing some improvement somewhere.
Mhm.
If they have 30 symptoms that they're experiencing, the main one that's driving them crazy, the headache or the pain may not be the first to go. But a lot of times they don't recognize, oh, yeah, the ringing in the ears has resolved. My night sweats have resolved. So we want to see that there is some symptom improvement. Otherwise, we pivot. So, every 6 weeks. And then when we move into herbals, it may be less often. So I would say the treatment in a patient who's chronic can be as little as 3 months and it can be upwards of over a year. It just depends on how much they can handle at one time. What is their constitution when they came to me in the first place?
Mhm.
What is their situation at home? Are they working full time? Are they a full time student? How much time do they have to commit to this? So,
So, in your practice, if you could define for me what is a good outcome, what do you desire for your patients when they walk in the door at the end of the line? What does that look like for you?
well, first, I think validating their symptoms is the most important thing so that they can not feel that they have to convince me that what they're experiencing is real. So you create a safe space for them when you first validate them rather than gaslight them, and tell them, well, everything looks normal here. So
I have to tell the story. My wife was going through her mold symptoms, and she was having a lot of shortness of breath. Now, this is a woman who runs 10 miles a day kind of person. And she goes to her primary care physician, and she's like, "Yeah, I'm having these symptoms." And the response was, "Well, you do talk fast." I wasn't there, but I will tell you, if I was, I would have lost my everything,
yeah,
you know. And
what
my
does
wife,
that even have to do with anything?
no, it's like, yes, she talks fast, and she
Yeah,
also runs 10 miles, and she still feels like she has a hard time breathing.
yeah,
Let's talk about what else that could be other than the fact that you talk. And she's always talked fast. It's like there's so many things wrong with it. We have our own, and again, this is our own personal experience trying to find. But I know that people have to relate to that. They're going to their physicians, they're going to the traditional model, and they're not being heard. And a lot of times, it's not necessarily the person. In my case, my wife's case, that was the person. That was just a bad clinician, whatever. But the reality is that a lot of times it's the system that just limits a very loving, caring practitioner.
yeah. Well, and I think that we have to bring our egos down enough to say that I don't know the answer.
Hmm.
Medicine doesn't have the answer to everything. It is an evolving science. You
Hmm.
know, Back in the day, we used to think that gastric ulcers were caused by stress. Now we know that H. pylori drives the majority of gastric ulcers. So it is an evolving science. And so, what we don't know today, we just need to remain curious.
Hmm.
Okay. Because you don't want to shut the door on someone to their symptoms just because you don't have the answer to it.
Hmm.
Somebody else may be. So, just being able to point them in the right direction and say, I'm not sure,
Yeah.
is key.
I think most patients recognize, like, when we're like, I don't know. I think they respect that more than us trying to make stuff up.
Yeah.
Um, it's okay for us to say I don't know, but there is someone that I can consult with, or there is someone I can refer you to, or there
Mhm.
is some research I can do to double check some things. And then when you come back, or when I'll follow up with you. I know in our practice we will give our cell phones to our patients if they have problems,
Mhm.
in between sessions, because I would prefer someone correct the exercise or correct the technique I gave them yesterday
Yeah.
than coming in a week later saying I didn't do it right. You
Mhm.
know, I know that your integrative practice deeply cares about people, and your goal is to build that trust so that you guys can walk forward together as a team,
Mhm.
and not. I always tell people I'm a guide to your healing.
Mhm.
I am not the end all be all,
Mhm.
and we are a team. You're not as more important than me. I'm not as more important than you. We are working together for this common goal.
Yeah.
One of the things that's always important to me is when someone comes in is like, what do they want? If there was the one thing I can do for you, because sometimes people come in with multiple symptoms,
Correct.
multiple problems, and like you said, the one thing that they're really just driving them insane might not necessarily change right away, but some of the smaller things do.
Yeah.
But understanding what it is that they're hoping for is really important. When the treatment is over, what are you hoping for that person?
I'm hoping that they can keep this infection in dormancy.
Is that the term dormancy? Do we ever get rid of this infection?
I think there's not a solid answer on that, but the conclusion amongst ILADS practitioners, which is the International Lyme and Associated Diseases community, is that we put this in dormancy, just like a lot of other chronic infections. You've got
Mm,
hepatitis and you've got herpes virus. You have the herpes zoster, which is shingles virus. These things live in us forever. Our immune system keeps them dormant. So the goal is to strengthen the immune system and so that it can keep it dormant. And that usually requires just looking at overall lifestyle practices. I usually tell my patients, look, you can't compare yourself to your neighbor who, stays up all night, drinks, has a poor diet. You're going to have to be a little bit more careful about your practices, protect your sleep, protect your diet, make sure you're utilizing some stress management practices to be able to keep the immune system strong.
You were exposed to the integrative model early on through a personal experience. If you were talking to a clinician now that is kind of on the fence or kind of sees some of the value or is curious to this model, what would be some advice or some suggestions or things to consider for that person?
Yeah. Go do a CME course. There's so many different organizations, some of the main ones that come to mind. I did my training through A4M, which is the American Academy of Anti-Aging and Regenerative Medicine. There is also IFM, the Institute for Functional Medicine, and they very closely mirror each other. I mean, they share a lot of the same instructors. So take one of their courses. That's what we did, and our minds were blown. It was looking through an entirely different lens than we're accustomed to. And so go take a course. There's others. I don't know all of them, but we all have to do CME activities. So go do one in a different area that you're not, knowledgeable on. And usually that opens the door to more curiosity.
So let's say you're talking to clients or patients or future patients, people who are dealing with these just common folks. What would you suggest they do? What's their first step if they are like, wow, I have those symptoms. What should I do about this?
Probably find a qualified practitioner. So, for instance, ILADS is a major organization, International Lyme and Associated Diseases Society. They train a lot of practitioners. So people that have gone through their trainings are usually recognized on the website. There's a find a provider section that they can look for someone in their area that might be trained. Same with mold. There's the ICEA, which is International Society for Environmentally Acquired Illnesses. They also train practitioners and have a directory of both practitioners as well as environmental specialists who are trained to be able to detect mold or be an advisor to people who are going through remediation processes. So that's a good way that they can find people. Um, Honestly, I don't think you see a whole ton of people who claim to practice in these fields that aren't knowledgeable because it is not an easy field to practice in. So you can't really be a weekend warrior who took a little class and is like now proficient. Um, Usually people who are in this space have personally experienced, a family member or themselves going through it. So, um, yeah, I would look to one of these two organizations, the IFM, the A4M. They also have a find a provider section on their websites to find people that are trained in these areas.
Jessica, thank you so much for joining me today and giving us the rundown on mold and Lyme and what to do about it and kind of what the symptoms are. I think that this is really, really important because I think these are two of some of the most common reasons why people live in chronic illness that are not detected. So everyone, thank you so much for joining us here at Good Outcomes. And I just want to remind you that healing is possible. If good outcomes matter to you, subscribe and follow wherever you're tuning in. If you're a new grad or a young clinician and you're frustrated with the system and its outcomes, go to renewintegrativept.com, click Join Our Team to learn more about our residency program. And remember, healing is possible.